Anyway, today we have Larry Cohen and Sana. Oh gosh, Anna.
Shahimi. It's a hard one.
Yes, it is a hard one.
No, I wasn't being facetious. It is a hard one. Thank you so much, and thank you everyone for spending an hour of your afternoon, wherever you are in the world, with us today. My name is Sana Shahimi. I'm a program director at Prevention Institute, one of the co-editors of Prevention is Primary, and a passionate prevention enthusiast. So I'm very happy to be here today. What Larry and I thought we would do today is really have a conversation with all of you using this webinar technology, where we're going to share a little bit of information about our Prevention is Primary textbook. We're going to talk about what led us to conceptualize this book in the first place, and also the role that it really plays today, given everything that's going on with healthcare reform and the Affordable Care Act, why we think it's so critically important and can be used as a powerful tool to really shaping people's understanding of the issues. We're going to quickly walk you through the three elements of the textbook, and in so doing, we're going to share some key Prevention Institute tools and frameworks that are based on the elements of the textbook to kind of show you how you could use this information in practice. And so here we are. We're a good-looking bunch at Prevention Institute. I am going to let Larry introduce himself. So Larry is not only our executive director, but he also founded Prevention Institute nearly 14 years ago today, actually. Our anniversary is on October 1st. And Larry, why don't you tell us a little bit about what led you to found Prevention Institute in the first place?
Well, sure, and we are here in Oakland, California. There's a picture on the screen of our building. We hope you'll visit us. Actually, we're having a staff brunch next Friday to celebrate our 14th anniversary, so why don't you all drop by. The work I was doing before this, it became clear that while people were focused on very specific prevention issues, no group was actively translating for practice what worked on one issue, Sana, and then how that applied to others. So, for example, I was involved a number of years before the founding of Prevention Institute in the nation's first multi-city no-smoking laws. Clearly, there was a lot we learned from that, some of which is reflected in Prevention is Primary. I also worked with colleagues on traffic safety issues, infant seats, car seats, how we got the auto companies to eventually install airbags. We also did work on alcohol and drugs. We did work on violence prevention. Others have worked intensively with a great deal of success on issues like HIV and AIDS. But there was no place that was really consolidating that and creating what I would call a field of prevention. And that's really, really critical because prevention is so much of what's going to determine whether or not we're healthy or not, whether we need medical care, and the severity, if we do need medical care, of what that's all about. We learned from that approach the importance of norms change, the importance of changing policies, organizational practices. Also wanted to emphasize from the very beginning that when we talk about prevention, we're talking about everyone, but there are certain groups that are particularly disenfranchised, that are particularly in need of health services, in part because the quality of prevention work just isn't there. And so we really, really have always emphasized health equity. Many people have talked about prevention not using quality as a criteria, and so they've talked about brochures, they've emphasized health fairs. Those things probably have a place, but it's a very, very small place, and it's in a much broader context. So that was really the goal of Prevention Institute. There are a couple of other places that look at prevention in a cross-cutting way in different parts of the country, but for the most part, they're more from an advocacy perspective, not from a community strategy perspective, where we say what needs to happen on a national level, what needs to happen on a local level, how do they inform one another, what needs to happen on a practice level, what needs to happen on a research level, how do they inform one another.
That's great, Larry. And why don't you tell us a little bit about the current context for prevention right now in terms of the Affordable Care Act and health reform? Because I think this is a very important part of understanding how the concepts in the text right now almost have even greater relevance in the second edition than they did back when we published the first edition in 2007.
Well, I think that's really true. And usually when we talk about health care, we're thinking initially about health. And we see, the slide didn't come out quite right, but we see the factors influencing health are medical care, only 10%, genetics, 20%, and behavior and environment, 70%. And we believe very clearly behavior and environment are interrelated. So if we see prevention as the methodology for dealing with behavior and environment, and medical care as medical services as the methodology for dealing with medicine, we might expect that 70% of our $2.2 trillion budget would be spent on prevention, not as this picture shows, only 4%. And so that means we really, really need to think differently about prevention. And one of the things we've worked on is making the case for prevention. In a document we partnered with Trust for America's Health, we took a look particularly at chronic disease prevention and said if each community was going to invest $10 per person, for every dollar we invested, by the end of year one, that dollar would be returned, and we'd start to see the beginning of a return on the investment beyond the investment itself. And it varies by state, but on average, at the end of 5 years, we'd see a $5.60 return on investment. We use this knowledge both to influence thinking and very, very specifically to encourage that prevention would be part of stimulus funding, what's now called Communities Putting Prevention to Work. We said, gee, in a lot of things in the stimulus, we want to spend money on things that matter. We want to get people working. It's worth the investment. It's worth ultimately paying the bill. But with prevention, rather than paying the bill, when the bill is due, we're actually going to have savings. We're actually going to have money. Obviously, we've paid the money on prevention, but a great deal of savings in our health care funds, bills we don't need to pay, averaged as a $16 billion return to taxpayers. Clearly, it was very, very important to make this case, and it led also, in addition to stimulus funding, it led to the investment we see here for the next number of years in prevention as part of the health reform legislation. Now, the President yesterday proposed that $1.5 million growing to $2 billion a year, I'm not used to those B words, instead be capped at $1.5 billion. That's still a tremendous opportunity, but frankly, it's unacceptable. We could save money with prevention. More importantly, we're saving lives in misery. And really the focus of, I'm sure, the work of everyone who's listening in and participating, the 60-something people, and probably more than people, groups of people joining us today, is we've got to really emphasize prevention much, much more as part of our health strategy, both prevention as a standalone effort and also how to engage medical and health care services as part of our prevention strategy as well.
And I know that, Larry, that this past weekend on Saturday, you had the opportunity to participate in the 2011 Health Equity Summit, which was held right here in Oakland, which is where Prevention Institute is based. And it was convened by the Congressional Tri-Caucus, Asian and Pacific Islander American Health Forum, and the Association of Asian Pacific Community Health Organizations. And I know that you were really struck by the kinds of interactions that you had, particularly with emerging leaders at that meeting. And I thought that perhaps you could just give us a little bit of of your thoughts.
Yeah, it really was terrific. It really was terrific, Sana, and I really thank you for your leadership in encouraging us to produce this textbook and bringing it to scale, because the Tri-Caucus included Native American, Latino, African American, and Asian Pacific Islander leaders, and many of the leaders there are what I would call emerging leaders. And a number of people there have looked at the textbook, have increasingly been familiar with our work, and that's really what our motivation was for doing this kind of work, was really to say not enough people get prevention. We all understand it intuitively as individuals, but the healthcare system, the training, the organizational practices, our policies don't support that. And there was tremendous interest. I took people through a series of slides which show community pictures called What's Health Got to Do with It, in order to help people see that what happens in the community really very, very much determines our health.
That's great. And in fact, training future leaders was really one of the biggest motivating factors in wanting to spend the time to put together this textbook. The reason New Sector Alliance shows up there is because over the past year, I had the pleasure of working with one of these future leaders who was an AmeriCorps fellow and who was placed with Prevention Institute, and her job was to conduct outreach for the textbook, and not so much as much outreach for the textbook as really outreach with other academic institutions and sectors to really talk about the importance of prevention. And she, we benefited a tremendous deal from her engagement, and I like to think that she did as well. So with that, let's move on to talking a little bit more about the book. The second edition came out last year. The first edition was back in 2007. We're very proud that this is a textbook. It was one of the first public health textbooks that APHA co-published. The other publisher is Josie Bass. It covers 15 chapters. There are 46 contributors to the text. We include not only a lot of theory around prevention, but really the tools, concepts, and models for readers to really do something with the information that is presented. And in light of everything that was happening around the health reform debate, around the time we were putting the second edition to bed, we updated much of the information in the book to really reflect the current context. The book is divided into 3 sections. We're going to go through section by section and also share a Prevention Institute tool. Section 1 is really the foundation. It's about defining the issues that are related to quality prevention. We start by really explaining what primary prevention is and what quality primary prevention looks like. Because as Larry said, while there has always been a focus on quality health care, even though we may not always necessarily receive quality health care, the focus has been there, there hasn't really been as much of a focus on quality prevention. So we address that in this chapter. Larry also mentioned that health equity and addressing inequities is really, really critical to doing this work well. So we have a wonderful chapter authored by two members of CDC on the social determinants of health that addresses health disparities.
And I think we also, because there's always so much of an emphasis in health on deficits and problem, we made the decision early on that we would incorporate all that, but really do more of a focus on resilience-based approaches. So I think what we want to do is talk a little bit about a couple of tools that kind of have emphasized there, both of which have Prevention Institute at their origin, taking 2 steps to prevention, and then we'll talk a little bit about the spectrum of prevention.
So in thinking about how we take 2 steps to prevention. Let's run through the example of a car crash, which I actually saw one on my while I was dropping my kids off this morning, and my 6.5-year-old had a lot of questions about why this car crash had happened, and he actually asked a lot of prevention questions. But in the typical response, of course, to a car crash is medical care and treatment.
We better get that person to the hospital right away, call 911. I hope they come quick. And car crashes, of course, are one of the 5 leading causes of death, also of cost, also of serious injury, and also leaders in terms of inequity.
And for each of these leading causes of death, societally, our knee-jerk response to them is we need more medical care and treatment. But of course, intuitively, we understand that medical care alone, while critically important, is not enough to reduce injuries and inequities.
It only treats one person at a time. It comes late. Looking at that picture, you have to wonder, even with the best medical care, whether we'll be able to completely restore the well-being of the person who was there. In terms of that first diamond, not the primary determinant of health, that's the chart I showed you earlier, where medical care was only 10% of the determinants of health, and it's pretty easy to see that it's the driving that led to the health condition, not the medical care itself. So what happens if we take a step and say, wait a minute, let's look at the behaviors that underlay the need for this service, and let's see what you think when you see this picture. Doesn't that change the way you think about solutions? Is it possible to look at this and say, oh, medical care, Sana, that's the only answer?
Well, certainly, when I look at this picture, particularly considering my 2 boys, I think of something entirely different as a solution. And in fact, if we consider again those leading causes of death, we can make links between each of those leading causes of death and certain behaviors that contribute to those leading causes. And you can see that on this slide here.
Which shows that the behaviors are critical, but then the question, of course, we say 2 steps to prevention, is what underlies those behaviors. And let me show you this picture from the environment. And, you know, I know when we show this at face-to-face, people laugh, people gasp, and it brings home a very clear recognition. If that's the message, then clearly medical care alone can't be the solution. And in fact, medical care is only a needed follow-up because we failed to deal with this kind of an approach.
So what we just covered with taking 2 steps to prevention is a recurrent theme throughout the first section of the book. And the first section of the book is really set up in a way to help people understand the need for prevention from an environmental perspective.
And for those of you who are working in coalitions or teaching, we have 2 steps to prevention worksheets, which have where we've done the research and found out linked 13 community factors which we've identified in the research, which link with the leading causes of death and the behaviors associated with those causes. And so we have worksheets to help you think about, or to help groups think about, which ones are most relevant in our community. And of course, if this is an example of what's relevant in your community, this picture, then what are the strategies that you start to develop to make changes? For example, in South Central LA, they reduced the number of liquor stores, and when they looked at the liquor stores that had been ultimately weren't reopened due to zoning restrictions, they saw a 27% reduction in serious crime in the 4-block area around those liquor stores. So we really want to tie the environmental issues to strategies and solutions.
Another one of the big tools that we cover in the first section of the book is the spectrum of prevention. Now, Larry and I both travel across the country. In fact, Larry travels across the world. He just came back from South Africa talking about prevention. And one of the frequent questions we get asked is, well, how do you do prevention? What does a comprehensive prevention strategy and approach look like? And our answer to that is always, it looks like the spectrum of prevention. Larry, why don't you take us through a little bit of the thought that went into creating the spectrum of prevention in the first place, and then I'll run through a quick example.
Well, as I said, the spectrum was really developed because too many people thought prevention was just brochures, just information. You can see that all 6 levels are important, and if you've got a good eye for the slide and a big screen, you'll probably notice that they get progressively bigger. That's because the levels at the top of the spectrum influence everyone. Individual knowledge and skills obviously is aimed at individuals. Community education is just aimed at learning, educating providers. Very, very important, but aimed at a small subsector. But as we start to think about organizations, from our businesses to our healthcare institutions to the places where we work, we start to see we can make macro change and really start to have an impact on norms, and even more so with policy and legislation. So what we say is the spectrum prevention is a tool for changing systems, norms, and environments, and each of the levels. And different people are comfortable doing work at every level, but often when we use the spectrum for an assessment in a community coalition, we find people all say, oh yeah, we're all working at one level, and it turns out it's just educational, and frankly, that's just not adequate for making major change.
And we really focus a lot on the need to change norms. Because if we think about the 2 steps to prevention exercise that we just did together, and we focus on those behaviors and exposures, what we really want to do, of course, is change the environment so that it changes the behaviors and exposures. And part of changing the behaviors is changing people's norms around health. You know, their attitudes and beliefs, what they take for granted. And the spectrum, by operating simultaneously and synergistically on all 6 levels, is a key tool for changing these norms. The best way to get into the spectrum is through an example. Now, if we were doing this in person, I would ask everyone a series of questions around breastfeeding. So we can't do that right now. But basically, if we think about rates of breastfeeding around, the late 1800s, early 1900s, we would probably all agree that the majority of women that could breastfed. And then, of course, into the 20th century, rates declined until they hit an all-time low in the U.S. in about 1972. Since then, rates of breastfeeding, of course, have gone up. Now, if we ask ourselves, what was it that contributed to the decreases in rates of breastfeeding, what are some of the things that people tend to share, Larry?
Well, certainly people talk about the advent of formula. They talk about the marketing of the formula, including, frankly, in some pretty unscrupulous ways. The fact that women were much more in the workplace. The fact that there was shame about bearing breasts, that breastfeeding was seen somehow as something that was lower class or sexualized or something like that. I'd say some of those are some of the kind of the main factors. Certainly media didn't portray breastfeeding as natural or normal the way these pictures on the screen do right now.
And then when we ask people the other question, what is now contributing to increases in breastfeeding, we hear things like the advocacy work of La Leche League, worksite accommodation policies that allow women to pump their breasts during the workday. We hear things like changing hospital practices so that formula isn't automatically given to infants at birth. We hear changing the practices of OBGYNs and pediatricians to really encourage women to breastfeed, the provision of lactation consultants. The point is, there's not one thing that contributed to the declines in breastfeeding, and there isn't one thing that has contributed to the increase. In fact, we can map out everything that Larry and I just said along each of the levels of the spectrum of prevention. And combined, it's the synergy between all of these activities that are leading to increased rates of breastfeeding. And that's really the power of the spectrum of prevention.
And more important than mapping it out retroactively, that's good as an example, but really thinking about what you're trying to accomplish in your community, what kinds of norms would be changed, what kinds of outcomes you're trying to achieve, and really saying, what are we doing on each of the 6 levels? And how are those pieces mutually supporting one another? And breastfeeding is probably one of the easiest examples, but we've seen this kind of work with tobacco prevention. You mentioned Sana. I was in South Africa. It was really amazing because there's a program in Cape Town called the Sankey Gender Center, and they were looking at norms around manhood and how those norms led to more violence against women, violence between men, HIV, sexually transmitted diseases, and they were very explicitly, this was very, very exciting for me, they were very explicitly designing their entire program, engaging their 30 staff along the spectrum prevention in a very well thought out and I'd say and a really effective manner.
And for those of you that are interested, there'll be our contact information at the end. We have many examples of how the spectrum of prevention has been used in practice that we're happy to share with folks.
But why don't we pause for a second and see if there are any questions coming in or if anyone has any questions so far, anything we can be clear about before we move on to the second and third elements of the book.
Great. Okay. Well, if anybody has questions, you can either type them into the question box, or if you're brave and you're confident that your microphone works, or if you've dialed in via telephone, if you want to raise your hand, I can unmute you. That's always a risky thing to do, but, it could work. So, I think we're good. I'm not seeing anybody spring to action, so we can allow them.
Well, we have more to say, and then perhaps later on we'll come back to it.
Yep. I'm sure they're in deep ponder as we speak.
Yeah. So the second section of the book talks about what it takes to be effective, working alongside communities to address and solve community needs, or working inside communities to organize from there. The power of the media, not just to get your name out or to get the word out, but to really influence the dialogue around prevention. We talk about evaluation, and evaluating prevention, people say you can't see, and since you can't see what didn't happen, there's no way to count it or evaluate it. That's nonsense. I was involved, for example, in motorcycle helmet laws in California, and we said we're going to build in an evaluation. You couldn't see the crash that didn't happen, but we did see after a year that the number of crashes that did happen was half the number of the year before. The number of serious head injuries is part of what I'm referring to. The number of deaths was half, not the number of crashes, but the impact of those crashes in terms of head injuries, and the cost was half what it had been. So we talk about this issue of evaluation under the leadership of Dr. Dan Perales wrote that chapter. We talk about how to engage in meaningful collaboration. And we've been looking increasingly at this notion of effective collaboration recently. So, Sana, maybe we should take a minute and talk about our coalition building tool.
Great. And Prevention Institute has several tools to support coalition building efforts. We've chosen to highlight just one here, but if you visit our website, we also have another wonderful tool. So what you see on your screen right now, and there's a chapter in the book that Larry has authored, is about the 8 steps it takes not only to build an effective coalition, but really to maintain the vitality of that coalition. And we know that coalitions continue, they're almost a fad in a way. Those of us that are funded for our work, it's almost a guarantee that our funders want us to start a coalition or join a coalition. And I know, for one, that when I went to public health school, while I was told over and over again by my professors how important coalition work was, no one talked about how to make it work. And no one talked about how to make being in a coalition, not just turn it into more work and headache, but really turn it into maximal outcome.
And what you're saying, Sana, is really important because somehow people think being in a group is natural. It isn't. I think 8 steps really, as you say, although it's about building a coalition, it's actually a very effective diagnostic tool. I think most of us can say we've been in coalitions that have been fantastic, and perhaps even more coalitions that haven't, in some cases annoying, in some cases a waste of time, in some cases maybe we go for political reasons, but it's really not adding value and changing things. This tool now is really time-tested, and people tell me again and again, this is the kind of stuff that enables them to think. It's designed for coalition leaders, and it comes from the perspective, if we're participating in a coalition, we are one of the coalition leaders.
Great. So again, an entire chapter devoted entirely to how you can use the 8 steps and apply it to your existing or new coalition. Okay, so we've covered, the foundational elements of prevention and the key tools and frameworks to how to do this work well. And then we come to the last part of the textbook, which really puts prevention into context. And each chapter in that book, and we've only listed some of the chapters up here, takes a particular topical area and applies prevention to it. So, we have a wonderful chapter covering the built environment, how to increase access to healthy food. There's a new contribution in the 2nd edition that takes on mental health from a primary prevention perspective, applies that concept actually to 3 case studies, all of which are very current, urban youth, immigrant communities, and also veterans of the wars in Iraq and Afghanistan. And then we have a updated contribution by one of our Prevention Institute colleagues, Rachel Davis, in collaboration with Dr. Deborah Prothero-Stith on preventing violence. And I actually want Larry to talk a little bit about the kind of work that is showcased in this chapter, because it is really a very unique contribution, particularly in a public health textbook context.
Thanks for suggesting that, Sana. This relates to our unity efforts, and I think what's clear now is we really know what to do to prevent violence. I think we could cut the rates of violence in any city by 50% without additional funding, but it requires moving funding, and that, of course, requires political will. Violence prevention is perhaps one of the most important equity issues. It's often neglected when we think about equity. It's often neglected when we think about health and public health, which is why we felt it was so important to put it in this chapter. Sometimes funders pay a lot of attention. The last decade or so, I'd say there's been very, very little support for violence prevention funding, and I think we're starting to see it grow a little bit again. I'm actually going to a forum I'm going to co-chair that Robert Wood Johnson is putting together at CDC in Atlanta that starts on Thursday on the links between violence prevention and increasing physical activity and also healthy eating. We know that violence not only affects, how we live and where we shop and where we work, but whether in a community there are places to shop, places to work, safe transportation. So as I say, it's a key equity issue. Unity looks at violence from the perspective not of the individual, but from the perspective where the unit of analysis is the city. We work in a number of different cities around the United States. This is a fairly recently updated map. But in addition to these cities, we're gathering findings and information which are relevant all over the United States. Some of our most important learnings are captured in the violence prevention chapter of Prevention is Primary, with the goal of giving the vision, the optimism, and the strategy, particularly to new leaders in the field, to people who are thinking about prevention for the first time, or at least really want to better understand how to implement prevention effectively. And of course, our website gives more updated information. We're continuing to learn. We're continuing to put out profiles and examples, and I'd love follow-up conversations with anyone on the web forum here if you're engaged either in one of these cities or in another city where you think that kind of work can be helpful.
And I'm just going to go back just for a moment and share another tool that you can access through our website, which is Communities Taking Action. This is a database of work that different communities across the country excuse me, have engaged in using the principles of prevention and really applying it to help to achieve greater health equity in those communities. And as you can see, we have many, many examples across the country, and this database is, meant to be used as inspiration for those of you that may want to engage in similar efforts. We cover everything from addressing food access to the built environment, to violence prevention, to the intersections between violence prevention, healthy eating, and physical activity. So I encourage you to use that as a resource. So we want to wrap up. We have, Larry and I are both fast talkers, so we've gone through a lot. And now we really want to open it up for some thoughts and questions from the group. And we also have, walk through in a moment, we have some examples of where prevention is is currently used, as well as where some of our current tools and resources are being used.
And I would say we've been really, really happy. Josie Bass told us, our publisher, that it was one of the fastest selling textbooks they've ever had. We've been really, really happy with the response, and nevertheless a little dissatisfied, and I hope you can all help us here. And I'm not sure the list we have up there is really a complete list at all, because I talk to people who are telling me the book is being used. But I think it's critical for all our health and well-being to change the thinking of the next generation of leaders. I think changing that thinking, this is one, but it's one, I hope, very, very important tool. So if any of you have any ties with schools, whether it be undergraduate, graduate schools, medical schools, public health, allied health, nursing schools, social work, we really want to get the book out there, as well as our overall model and framework. Chapter 1 of the book is available on our website for free. We could certainly help people. Certainly there's no goal. Obviously textbooks are a bit expensive, but there's no goal of ever letting that stand in the way. Virtually everything on our website, in fact, is free. Tools, materials, approaches, profiles. And it's just really a question of how we can all work together.
Super.
We'd love some comments, questions, or any other ways we can be helpful at this point.
Okay, well, we've got first question from Yuba. Let's see, I'm not clear about what is quality primary prevention. Are you going, is it going through the 6 spectrums? Will we be giving some examples of that?
Well, that's a great question, actually, and I'm not sure we can exactly define quality. I think quality prevention, maybe if I were going to define it, having said that, quality prevention is doing what it takes to maximize the reduction in the likelihood that people are going to get sick or injured in the first place. And always we know that quality prevention requires changing environments and changing norms. The 6 levels of the spectrum are part of the strategy for doing that. Naively, people used to say, just tell someone, and we know very clearly that that doesn't work. In many cases, we know what healthy foods are, we know what's good for us, but unless we take steps to look at what's being marketed, what's on the labels, how people are being persuaded or dissuaded, what's for sale in schools and communities, using that as one example. Unless we get engaged at all those kinds of levels, it's not quality prevention. I'm not sure that's 100% of an answer, but I think it moves in that direction, Sana.
It's a good answer. We actually, on the home page of our website, in the very middle, have this whole section that's called Quality Prevention Is. And Larry has covered many of those tabs. Well, what I'll add to that is that quality prevention really considers how to increase health equity also. So it's not just giving people information. It's not about brochures. It's about taking 2 steps to prevention. It's about planning comprehensively, using the spectrum, and doing so in a way that really increases health equity.
Great.
Thank you for the great question, Yuba.
And then she said, thank you for your really good answer.
Great.
I personally, I was unaware that you had so many great free resources on your website to support this kind of activities.
Well, you know, we started, actually I started Prevention Institute, as we said, 14 years ago. I started out of my house. It was an idea. Had enough money to about pay myself about 1/3 time. We're now 30 people. I think we're the only group that 24/7, and I'm sorry to say it's often literally almost 24/7. We've got 30 or more people who are really focused on this kind of work. And obviously we're focused, different people are focused on different elements. We've been focused on health reform. We've been focused on advancing equity. We've been focused on nutrition and physical activity. We've been focused on the links between transportation and safety, and transportation meaning bicycling, walking, public transit, as well as auto and truck safety. We've certainly been focusing on violence prevention. And we try and make all our materials particularly practical. We're also in a phase now where we're trying to increasingly get some of our work translated. Having developed tools, certainly they're aimed at the United States, but just as every community in the United States is different, there are ways many of our tools can be adapted for other places as well. We want to be responsive to the extent, you know, of course we're a nonprofit, so our finances are tight, but to the extent we can be responsive, we want to be responsive to people all across the world.
And I really want to encourage, you know, as additional questions come in, I want to encourage all of you to sign up for our e-alerts. We don't spam you, so we're very thoughtful in what we send out and when. We've recently joined the 21st century, so we tweet, not Larry and I, but others here do, and we're on Facebook and LinkedIn. And as people consider their questions, I want to highlight 2 particular resources for those of you that have an interest in engaging with media. We coordinate 2 rapid response media networks, one on issues related to prevention and health reform and the Affordable Care Act, and one on issues related to food and activity access. And what we do using those 2 networks is PI staff on a daily basis where synthesizing the news, analyzing the news, the online conversation, as well as the offline conversation, and sending you key information about what's happening, and also giving you talking points to allow you to respond to like the top issues of the day. So if anyone is interested in either of those networks, please feel free to sign up on the website.
Oh, I think
and
that's
otherwise,
great.
Are there any additional questions that have come in?
Yeah. I think that's absolutely fabulous, because certainly in a 24-hour news cycle, it makes it very difficult to distill what is really critical and what's just noise.
Yeah, that's why we work 24 hours.
Well, I appreciate that.
Oh, good. I'm glad you do.
Well, Kanitha said, thank you for the excellent presentation, very holistic in the conceptualization. Has the spectrum been applied to child welfare, such as abuse, neglect, and minimizing placements into foster care?
I would say in a general sense it really has. We've looked at the spectrum and we've looked at norms, and there's actually a document that's been produced, not related specifically to child welfare, called the Spectrum of Prevention and Sexual Violence. This document includes the 5 norms we've identified that are consistent in family violence and the kinds of changes that are needed for preventing them. And we've shared this framework and these norms with both the California and the National Child Abuse Working Groups, and in both cases have identified that these are the norms that need to be identified and changed, and that the spectrum is part of the solution to making those changes. So we don't have a document specifically related to children, but we do have these documents related to adults, and they tie, I think, very, very well in. But we'd love to see further work and further analysis of how this could be advanced even more specifically to issues like reducing institutionalization.
Wonderful. Yuba has another question. She's wondering if is the Affordable Care Act addressing, let me try it again. Is the Affordable Care Act addressing prevention strategies that we can talk about today?
Yes, particularly through the Prevention and Public Health Fund. So that's the fund, that Larry showed earlier. It's well, it was supposed to be a $17.5 billion investment over 10 years that now there's some cuts that have been proposed to that. That fund has already gone to partially support an effort that was originally paid through the stimulus called Communities Putting Prevention to Work, where 50 communities across the country have gotten money to address precisely the kinds of issues we've talked about today from a prevention perspective, particularly addressing tobacco use, eating, and physical activity. And at any moment now, though probably not at any moment, probably next week, we expect to hear who the Community Transformation Grant awardees will be, which continues this investment in community prevention.
And there's a couple of other pieces of the Affordable Care Act that are particularly relevant to prevention. We've worked very hard to figure out where do we really encourage prevention. And there's a whole section on community clinic funding, which is designed to expand community clinic capacity so they can serve more people. But I think community clinics are particularly sensitive to the fact that they're serving people in their communities. And we've made the point with a document on our website called Community-Centered Health Homes, and I imagine you can find it right on the front page of our website, with a document called Community-Centered Health Homes, that there's a way to design community clinic work so that it really identifies the problems that are bringing people into the medical institutions and the community solutions that will reduce the number and severity of those problems. There's also another fund which is part of Affordable Care Act called CMMI, or the Center for Medicaid and Medicare Innovation. And they've got $12 billion. One of 3 buckets of that money is to explore what they call population health, which is really about community. How do we keep communities healthy? And we've proposed that this community-centered health homes approach can be an important part of their strategy. What they're saying is it's not just the money there, but any strategy that makes sense in saving money, and we think prevention will save money and save lives, could then be automatically implemented across the nation's entire Medicaid and Medicare system. So there's tremendous potential with the Affordable Care Act to think about communities, populations, keeping people healthy. Obviously, the Affordable Care Act is not perfect. It needs to be improved as we move forward, but it's a tremendous opportunity, tremendous resource for thinking about prevention in a new way in this country. We've never been able to think about it and implement it before.
Yeah, very exciting. Well, let me, I'm going to mute myself and let you finish up for the last couple of minutes, and keep asking those questions, because if we run out of time, I'll still get those questions to you guys when we're done here. so you can
And
follow up individually.
And I just wanted to say we'd love to hear from people, and my email address directly is larry@preventioninstitute.org, and Sana's is Sana, S-A-N-A, @preventioninstitute.org. And we'd love to hear from you, your reaction, whether you found this useful, if you'd like us to add you to the database. I learn a lot of times that people don't make comments in big groups, but then follow up, and I'd be very appreciative of that information.
Wonderful.
So I think in closing, what we really want to emphasize is that we're really at a critical juncture in our nation's history when it comes to having a really meaningful opportunity to change the trajectory of health, well-being, equity, and safety in this country. If we all work together and really promote the community prevention approach as opposed to business as usual. And that's going to take a unique kind of leadership, a unique kind of vision, and it's part of what we're trying to lay out in prevention is primary. We know that this is an iterative process. We're not saying that this book is going to solve everything, but we have gotten a lot of tremendously positive feedback, both from, as Larry mentioned, emerging leaders, but also from those of us that have been doing this work for a long time. And we really are very committed to engaging in an ongoing dialogue with each of you about how we really get these frameworks and principles out there in a more meaningful way. So please don't hesitate to contact either Larry or myself with any questions, any comments, any thoughts you have on how you might be able to use any of our frameworks, or any questions you have about how to best use those tools and frameworks.
Yeah, I would just say in closing, this stuff is very, very serious. We're talking, there's our shared lunch table. We're really talking about saving lives. We're talking about saving money also, but we're really talking about saving lives. I mentioned that a couple of decades ago I did the country's first no smoking laws. Now in California we have half the number of people smoking that we did then, or to put it another way, just as many people not smoking as smoking among the previous more likely to smoke. That's really, really important. We know how much health matters to all of us. It's time to build a movement. I hope we'll all be in this together. I hope we can work together. We're here to assist you and appreciate how you've participated in this quietly for the most part, and how we will work together assertively as we move forward. Thank you all so much for being here.
Thank you, everyone.
Well, thanks, you guys. That was really fabulous. I'm so excited to see all the great things that you guys are doing, and I hope we bump into each other at APHA in a few weeks.
Looking forward to it.
All right, take care. Thanks, everyone, for attending. See you soon. Bye.
Bye, everyone.